Good evening. Welcome to our community forum on the End of Life Options Act that is currently before the Massachusetts legislature. My name is Chuck Francis, and I am the action team leader for Essex County, and we are sponsoring this event. I'm delighted to be here with you tonight, and by way of background, I was originally inspired to work on this campaign 2 years ago after I watched a presentation similar to this evening's. For several years, I had wanted to find an organization like Compassion and Choices, and because I had watched two friends and one relative die in agony with no legal options but to suffer, and suffer they did. The 2 years have been very hard work, but the Compassion and Choices professionals and volunteers like myself have been outstanding. I hope that some of you will join us going forward. After a few brief introductions, you will hear an amazing personal story and presentation from a person who has dedicated the last several years of his life to this effort and his work on the medical aid in dying, which lies at the heart of this essential legislation. Now, I will turn over this meeting to my friend, Joanne Viziello, one of our outstanding volunteers.
Hi, everybody. Good evening. As Chuck said, I'm Joanne Viziello, and I live in Wenham, Massachusetts. I want to thank you all for joining us this evening to learn more about medical aid in dying and the End of Life Options Act in Massachusetts. I first became a proponent of medical aid in dying decades ago when I watched a young woman suffer a long and very painful death. In more recent years, I've listened with a heavy heart as many close friends have described to me the stories of the passing of one or sometimes both of their parents, again, with very prolonged and suffering events, even when hospice was involved. So I understand both how important and also how compassionate this act is. And now, as someone who's been diagnosed with incurable blood cancer, I also understand the urgency of getting this act passed into law in Massachusetts. So again, I thank you all for being here tonight. It is my hope that after tonight's presentation, you will be inspired to reach out to elected officials in Massachusetts and urge them to pass this important piece of legislation. And now I'm going to turn it over to Abby Rhoden. Abby is the campaign organizer for both Massachusetts and New England at Compassion and Choices. Abby.
Hi, Joanne. Thank you so much for giving me a great introduction. Like Joanne said, my name is Abby Roden, and I am the campaign organizer for Compassion and Choices for the Northeast and Massachusetts. I have been a passionate advocate and supporter for medical aid in dying since the summer of 2018, when my father died a bad death due to stomach cancer. He very badly wanted to access medical aid in dying, but was unable to due to the legislation and the law that was in the state that we lived in. I am thrilled to be working with so many passionate volunteers and advocates from across the Commonwealth, fighting to pass medical aid in dying in Massachusetts, including Dr. Roger Kligler, our speaker today. For over 7 years, Dr. Roger Kligler has proven to be one of the strongest advocates on behalf of the end of life, the aid in dying movement in Massachusetts. During that time, he helped educate hundreds of people about the issues of medical aid in dying. Today, it's an honor to introduce Dr. Roger Kligler, who will be giving a presentation and answering your questions following this presentation. Please wait until the end to ask your questions. You can put them in the Q&A feature, and they will be given to Dr. Roger Kligler at the end of the presentation. Thank you, Dr. Kligler. I'm turning it over to you.
Thank you so much, Abby, Chuck, and Joanne, for having me. And thank you to all our guests coming to hear my story, The Death I Want, A Physician's Journey into Medical Aid in Dying. I'm a volunteer for Compassion and Choices, which is the nation's oldest and largest nonprofit committed to improving care and expanding options at the end of life. Atul Gawande said in Being Mortal, life is meaningful because it is a story, and in stories, endings matter. However, while my journey is still in progress, I am working to be able to have the ending that I want, to die with the option to minimize intolerable suffering. I have incurable metastatic prostate cancer. I am a physician who cared for people during their end of life. I want to share my story, my thoughts about medical aid in dying, to talk about 24 years of experience in Oregon and other states, and to give you an update about what's happening in Massachusetts. What is my background? I wanted to be a doctor since the 5th grade. I found my two loves while I was in medical school at Georgetown, my wife of 42 years and mother of our 3 children, and internal medicine, which is adult medicine, which I practiced in the hospital and in the office. After medical school, I developed an addiction. It's called workaholism. I worked in Brockton, which is a diverse, underserved community. These were really different times. I was able to follow patients across a continuum. I took care of them when they were in the office. If they got sick, they went to the hospital. I was there attending. If they got really sick, they went into the intensive care unit. And if they had a heart attack, I'd take care of them in the coronary care unit. I was there attending, and I took care of their primary problems. I was also involved in end-of-life care. And I always felt strongly that I should be there for my patients on hospice. And I took care of patients when they went into the nursing home. I had many experiences with dying, including people with chronic illnesses, and I was their primary doctor directing their care. I took care of people with cancer, including prostate cancer, after the specialists were done with them and said, there's nothing more we could do. They would come back to me for their terminal part of their care. I dealt with people terminating treatments. I've taken people off ventilators, and I've had discussions with patients about whether they should stop dialysis with kidney failure, meaning that they would die of their kidney disease. I had patients who needed terminal sedation, which was when people were in such bad pain that we were unable to get their pain under control, and gave them morphine drips to the point that they would become unconscious and die more comfortably. And I had people ask for aid in dying. And that was one thing that I felt I couldn't do. So I had the patient saying, I'm ready to die. And I was more afraid that I would lose my license and not be able to practice and take care of my family. I help people to realize that death is inevitable. That sounds kind of funny. People all know that they're going to die, but they have magical thinking that it doesn't apply to them. And not till they start getting sick do they realize the truth in this. I help people to decide how much care to get, and when too much care is worse than less care. And by necessity, I did palliative care before there is such a specialty. As I matured as a clinician, I tried to discuss objective of care with my patients, improving their quality of life, end-of-life planning, which has to do with what their values are. And I counseled people at their end of life for care goals. And the care goal was to continue to live, that they weren't dead yet, and their life hadn't ended, although they did have a terminal condition. So how did I learn about death? I'll tell you, it's something that wasn't taught in medical school, but I had many teachers in my life. My dad used to tell me that there are things worse than death. And when I needed to take him off a ventilator, I knew exactly what he wanted. He also taught me not to buy green bananas, that life is short. I had a patient, CD, who was in his mid-70s. I was a young doctor, and we were talking about what care he'd want at the end of life. And he said, you know, I've lived a good life and I'm ready for death. And that had me completely perplexed. And I still remember it this day, which is over 30 years ago. I had a doctor that I took care of who had a cancer. And I was able to say that there are new medications out that can help him. And he said, no, I don't want that. I don't want any aggressive treatment. I'm in my late 70s. I only want comfort care. Even if there's a treatment that works, I'm still old and will die. And treatment can cause more harm than it can help. And from these people, I learned about the quality of life. So we all have a personal side of death. So at age 40, my wife and I had 6 family members who died in the course of a year and a half. This included my mother, who died of pancreatic cancer, and my wife's father, who died of an abdominal sarcoma, which is a soft tissue cancer in his stomach. These were difficult and lingering deaths. And I decided I would want options at my end of life. I wanted to decide when my suffering was more than I could handle. And like many physicians, even those opposed to medical aid in dying, I wanted the option not to suffer at my end of life. My first impulse was to think only about my life. Much later, I started to think about justice. So justice is the ability of 2 people in similar situations to have the same outcome. So if I, because I'm a physician with my training and understanding, could end my life without having to suffer, other people should have this as well. So what was my transition to patient? In 2002, I turned 50 years old. And like a good internist, I went and got my PSA drawn. Now that's a screening test for cancer. And it came back elevated. I called up my urologist and he said, come on down. And they did a biopsy. And one tiny little piece of the, one of the cores, they took 6 biopsies. One little piece showed a little bit of cancer. I had a prostatectomy, which means I had my prostate removed. And it showed some aggressive features when I looked at the pathology. But I was told, everything's okay. Your PSA is 0, you're cured. And I was back to work in 3 weeks. However, having cancer is a journey. Gradually, I started having small elevations of my PSA, which is a blood test that you get for following prostate cancer. I was told there's nothing to worry about. So I ended up going for a second opinion. And they said, you need to have salvage radiation and hormone therapy. So salvage radiation is what it sounds like. They're trying to salvage a cure by giving you a course of radiation. And so every day before work, I'd have radiation in Boston and worked in Brockton. And one day I noticed there was a ventilator, a breathing machine in the left-hand corner of the room. And I sat, and I'd been in hospitals all my life, and I couldn't figure out what this was about. It was there one day, it was there the next day, it was there the next week. And then I met with my radiation oncologist, and I said, Tony, what's that ventilator doing in the room? And he said, it's for the children. And all of a sudden, I realized that I had nothing to worry about, that they needed to have little children who couldn't lie still for 3 or 5 minutes to get the course of radiation. They had to be put to sleep, put on a ventilator. And I knew that some of these children would not survive. Here I was 55 years old. I had great parents. I always had a roof over my head. I had food in my belly. I had the best schools. I had a wonderful wife, 3 wonderful children, and I had a job that I would have done for free, and they threw gobs of money at me. And I said, what do I have to worry about with this? And I accepted my mortality at that point. And I call that the gift of cancer. And I understand about living each day as precious. Now, this is my philosophy and how I've dealt with my disease, and I realize other people may feel differently. So my PSA was 0 after treatment, but then it started to rise. And once it rose, it became incurable. I developed a metastasis that they found in 2011. They put me on hormones at 2012. And when you go on hormones for prostate cancer, it's like going into menopause. So I suspect that there are many in the audience who will understand it, but I was sweating all the time, hot and cold sweats, difficulty sleeping. I'd be talking to my patients and I'd be wiping my brow. It was really quite an experience. When I talk to my patients about menopause, I'd say, oh, I know exactly what you're talking about. I don't know what they thought, but I did. I had to stop work in 2015. I was age 62, and I had multiple medical problems that stopped me from working. In the spring of 2016, I had one of my hormone shots, something called Lupron. And you always have pain after it. And usually it lasts for about a week, but it's really uncomfortable. You can't sit comfortably. You can't lie on that part of your body, wherever it is. But this pain never went away, which was a bad sign rather. And so eventually I examined myself and realized it wasn't coming from the shot. It was coming from somewhere else in my pelvis. So I called up my oncologist and she said, come on in. And we did a MRI, and it showed that I had an 8-centimeter mass, about this, well, you can't see that, about this big. And she said, we're going to go ahead and give you radiation, and we're going to give you immunotherapy. So I also was told, because the hormones were no longer working, that I had castrate-resistant prostate cancer. And like everyone else who has cancer, I went to the internet and saw that my median survival was 17 months. And with the immunotherapy, with Provenge, it got my median survival up to 25 months. So I should be dead by now, but I'm very fortunate. And with the radiation, it killed off the really bad part of the cancer. And I now have, or at that point, I had castrate-sensitive prostate cancer. So it's improved and it stabilized for 4 years, but my cancer was still present and started to get worse. And I had the resistant prostate cancer again. The past year has been a roller coaster with my cancer. My PSA was doubling every 6 weeks, which is a really bad sign. That means my cancer essentially is doubling every 6 weeks. I had an initial workup. They couldn't see anything. 4 months later, they saw 5 metastases in my spine and my pelvis. I underwent my 4th and 5th courses of radiation. Really knocked me for a loop. I was very debilitated, but my PSA has come down 87%. Later this month, I'll have staging again where they look where my cancer is. I get blood work and a bone scan and CAT scans, and they'll see how I'm doing. And this will help give me an idea of, whether I'm, very, very lucky or just lucky. So I started working for medical aid in dying 1 week after I stopped my job. And I came to something called Death Cafe or Death Education in 2015. Marie Manis was there, and Marie was Abby's predecessor, and she talked about medical aid in dying. My wife, Kathy, and I talked and decided to become involved with medical aid in dying. We decided that night. So it was a talk just like this one. It felt right to me for my patients who died suffering and wanted a better way to die, and for our parents who had died with a lot of suffering. I was also motivated by a young woman by the name of Britney Maynard. I don't know how many of you remember Britney. She's a 29-year-old Californian, and she had been married for about a year and then developed headaches and had a brain tumor in 2014. She was very media savvy. She had a horrible illness, and she decided that she didn't want to die without medical aid in dying, so she moved to Oregon. She eventually died there, and she asked her husband, Dan Diaz, to try and get California to legalize medical aid in dying. And I realized that I could add my understanding for medical aid in dying as a doctor, as a patient, as someone who practiced palliative care to the conversation. But this would require my giving up something that was really important to me, my privacy. So what is medical aid in dying? It's the practice where a mentally capable adult with a prognosis of less than 6 months to live requests from their doctor a prescription that they may self-ingest medication to bring about a peaceful death. There are many safeguards. So what are the safeguards in Massachusetts? And they vary state to state. You have to be an adult resident. You have to be terminally ill with less than 6 months life expectancy, which is the same thing as hospice. 2 doctors have to certify that you are terminally ill, that there's been no coercion, and that you're competent to make the decision. You have to have a mental health evaluation to show that there's no impaired judgment or coercion. You have to request it yourself. Again, no coercion, and no proxy can request this for another person. You have to self-ingest either by mouth or you can do it through a feeding tube. It's voluntary for the doctor and pharmacist. There are 2 requests that have to be made, 15-day waiting period. You have to have 2 witnesses, at least one who's disinterested. And the death is due to the underlying disease to protect things such as life insurance and to have more accurate medical records. So how have the safeguards worked? There's not been a single case of abuse or coercion, nor any criminal or disciplinary charges have been filed across the nation, not one. Disability Rights Oregon, which gives legal help for people with mental and physical disabilities, have said there have been no complaints of coercion. And the only complaint is that the act might discriminate against people whose disability prevents self-administration. Medical aid in dying is not suicide and is not euthanasia. Why do I say that? What is euthanasia? Euthanasia is when another party gives a treatment, intentionally killing a person or animal with incurable illness or injury. It differs from medical aid in dying as the individual needs to self-ingest the medication voluntarily. Euthanasia is illegal in all states for people and is the standard of care for pets. What is suicide? Suicide is a premature death hastened from psychological despair with impaired judgment. An example is jumping from a building. However, on 9/11, as many of you might remember, a number of people jumped from the World Trade Center. The medical examiner had to make a legal determination of the cause of death. And he said they didn't go to work planning to die. They made a rational, autonomous decision, and the death certificate recorded that they died secondary to terrorism. Like these people who jumped from the World Trade Center, medical aid in dying is when a person with a terminal illness, no chance of escape, is making a rational, autonomous decision. And unlike suicide, they don't want to die, they only want to end suffering. Usually they don't take the medicine until the suffering is severe. And just as when someone dies in surgery, the cause of death is the underlying disease. And the purpose of the death certificate is to keep a statistic on the illness. And so this accuracy is really important. Suicide is almost always secretive. Medical aid in dying is always collaborative. Usually, people discuss it with their families or loved ones for months before they talk to a doctor. They always have to discuss it with 2 doctors, and in Massachusetts, a mental health professional has to evaluate them. This is part of the reason that the American Academy of Suicidology and the American College of Legal Medicine, as well as state laws, differentiate medical aid in dying from suicide. Opponents argue that medical aid in dying is suicide, and they give it the attributes of typical suicidal behavior, such as depression, and that people would take the medicine as soon as it's available. People don't want to take medical aid in dying to die unless they really are suffering to the point they can't handle it anymore. They also say that this depression is amenable to treatment with antidepressants, which it is not. So we now have 11 or 10 states in the District of Columbia that have medical aid in dying. In 1994, there's an initiative in Oregon which passed. This was done after seeing many people dying horrible deaths of AIDS before we had medications. This was stopped in court, and subsequently the legislature said we should have a second initiative, and it passed by a wider margin. So we've had 24 years in Oregon of experience. About a decade later, in 2008, there was an initiative in Washington, and it passed. In 2009, in Montana, there was a court case, the Baxter decision. Baxter sued, saying that he had a constitutional right in Montana for medical aid in dying. The lower court decided on the day he died that he did have this. And subsequently, the higher courts said that medical aid in dying is legal there. Ironically, his grandson benefited and was able to take medical aid in dying when he died of pancreatic cancer. In 2013, we have the first legislature passing medical aid in dying in Vermont. In 2015, the California legislature, largely through the work of Britney Maynard and many others, passed legislation. In 2016, there was another initiative in Colorado that was well-funded and passed by 2-to-1 margin. And then legislatures passed in 2017 in the District of Columbia, 2018 in Hawaii, 2019 in New Jersey and Maine, and just earlier this year in New Mexico. So to help you understand what end of life is like, I'm going to make a description for you to help you better understand why people decide to use medical aid in dying. I want you to try and walk in the shoes of someone who's at their end of life. Unfortunately, some of you may have experienced this during the death of a loved one or friend. So at end of life, many people are unable to do activities that most people take for granted. They may not be able to walk across a room, make food, go to the toilet themselves, dress. Many are in chronic pain. They take pain meds all the time and still have pain. Many are short of breath. They have low oxygen levels and they have low blood counts, which gives them a breathless feeling all the time. They feel weak, they feel drugged. They rest and sleep much of the day. When my mother was dying, her activity of the day was to eat breakfast. They often have loss of appetite, weight loss. They become gaunt, a bag of bones. They often have nausea, vomiting, and constipation, much suffering. They're unable to travel, and so moving to another state is beyond them. Unfortunately, even with hospice and palliative care, many people die suffering. They're taking pain medicines around the clock, and they realize that today is the best day of the rest of their life. Please think about that. Might you want an alternative way to die? There's an article this week in the New England Journal about a patient at Dana-Farber on palliative care. So this is someone getting the best of care in one of the best institutions. It was an 83-year-old who had cancer, and he also had a pain syndrome. For days, he was agitated and calling out for help. The author, who's a palliative care doctor, said, his could have been a good death. It wasn't. Even at the best hospital with experienced and skilled clinicians, some people die horrible deaths. And we are all one terrible death away from supporting medical aid in dying. So was this patient unique? So studies show we're doing a poor job with end-of-life care. 26% of people, that's like 1 in every 4 people who die of a chronic illness, die with uncontrolled pain. 21% die with uncontrolled shortness of breath. More people die in the hospital than at home, and most people want to die at home. It's starting to change, especially in Oregon. If you're in the hospital, families say that 11% of people get more treatment than they want, except if they're in the ICU. then that number goes up to 21%. So how do people in Oregon get to medical aid in dying? About 17% of the terminally ill discuss medical aid in dying with families, usually months ahead. Doctors say 2% of people talk to them about it. If you ask families, it's 10% of people. 6 out of 1,000, 0.6%, end up with a prescription. And there are between 3 and 4 deaths per 1,000 people in Oregon who die, who use medical aid in dying. And over the past 3 years, it's averaged to be about 200 a year. A third of people who have gotten prescriptions for medical aid in dying don't use it, but it helps to relieve anxiety. These people don't want to die. They just don't want to suffer. So who are the people who use medical aid in dying in Oregon and Washington? 3/4 of them have cancer. 11% have neurologic diseases, such as ALS. More people are starting to use it with end-stage heart disease. The people tend to be older. 80% last year in Oregon were over 65. Over 90% are in hospice, and they stay longer than non-users of medical aid in dying, 45 days. Hospice and palliative care are great. They improve the quality of life over usual medical care and giving people 5 weeks longer to live. Almost all the people who get medical aid in dying die within 6 months. About 3 or 4% of people outlive the 6-month prognosis. Studies show that poor, uninsured, and people of color do not get pressured into using medical aid in dying, and it's illegal for insurance companies or others to coerce people into medical aid in dying. Recently, Oregon passed an exemption to the law to make it accessible to those expected to live less than 15 days. Last year, it opened it up to 75 more people were able to access medical aid in dying. That's an increase of 25%. And last year, total deaths were 245. These are people who are on death's doorstep. The Massachusetts law does not have that exemption. So how do people take the drugs? So they have to quickly drink a large number of dissolved pills. Recently, the drugs are Valium, which is a tranquilizer, digoxin, a heart medicine, morphine, and amitriptyline, which is an antipsychotic. Previously, they had used sleeping pills, barbiturates. Typically now, people fall asleep in 5 minutes and they die in less than an hour. That's the median amount, but some people can go longer. There are rare complications. People have difficulty with ingesting and vomiting, which is usually because of their underlying disease. And that's about 1.5%. And 4 people out of 1,000 had regained consciousness. And that was almost all on Seconal, but none of the people with the current medications have regained consciousness. So what has changed in Oregon with medical aid in dying? There are now better conversations around death and better knowledge and skill of physicians. It's improved the use of hospice, with more people getting to hospice, increasing the numbers from 20% to 40% of the people who die. There's more appropriate utilization of hospice. People are on at the right point, and more people are dying at home. There's better care for all. Something that's not talked about is that a number of terminally ill people commit suicide, and that's 1/4%. This virtually ends with the law being passed, and doctors tend to follow the law. I am suing the Commonwealth with another physician, Alan Steinbach, for medical aid in dying. Me, so that I have the option to obtain medical aid in dying from my physician, and Dr. Steinbach to have the right to advise patients about medical aid in dying and to give them a prescription without the threat of arrest. The Superior Court found against us in almost all the counts. An appeal is filed. We actually filed the paperwork this past week. Action by the state legislature and COVID slowed down the courts. The court did rule that physicians may discuss medical aid in dying with patients. So what is the support for medical aid in dying? 70% of Massachusetts and national polls showed the same thing, support it. A recent Globe poll came out, I think it was 2019. So absolute majorities of white, Hispanic, Black people, all age groups, Democrats and Republicans, liberals, moderates and conservative, religious people, non-religious people, 70% of Catholics and other religions, and greater than 50% of other Christians all support medical aid in dying. Doctors support medical aid in dying. In recent polls, 58% of doctors support this, and in Mass Medical Society did a poll of our members, and they found by 2 to 1, we supported having a law in the state. 12 medical societies, including the Mass Med, have developed a neutral position. And the AMA, American Medical Association, recently recognized that doctors can provide medical aid in dying without violating their professional obligations. So what's the history of medical aid in dying in Massachusetts? In 2012, we had an initiative. At that point, there were 60% of people who were in favor. We ended up losing 51 to 49%. The initiative was underfunded. We were outspent 5 million to 1 million. Marjorie Egan said that $700,000 came from the Archdiocese of Boston and 5 million came from the Catholic Church. And they had misleading ads. They said, for example, oh, there's no mandatory family notification, which of course can't be done under HIPAA, which says that people have a right to privacy. They threw 100 pills across the table and said, you have to take these in 3 minutes. But the reality is that they're dissolved and you have to drink 3 or 4 ounces of fluid. Legislation has been proposed in each session for the past decade. This session, there are over 80 legislators as co-sponsors. And for those who don't know, there are 200 legislators. Last year was the first time an act relative to end-of-life options was favorably reported out of the Joint Committee on Public Health, but it still died without action. It had bipartisan support then, and it has more bipartisan support now. We had a hearing at the Joint Committee of Public Health again on October 1st, and it went well. There are 18 members on that committee, and 10 members are co-sponsors of the legislation, including Senator Lovely and Representative Vargas from Essex County. Other co-sponsors in Essex County are Senator Crichton, Representative Minucci, Wong, Mira, Kelcourse, Nugent, Kerens, Ehrlich, and Capano. As I wrap up, I want you to consider the words of Governor Jerry Brown when he signed the California law. I do not know what I would do if I were dying in prolonged and excruciating pain. I'm certain, however, that it would be a comfort to be able to consider the options afforded by this bill, and I won't deny this right to others. So thank you for hearing my story about how I came to believe that I would like all of us to have the option for medical aid in dying during my lifetime. And I would like to be my legacy that I help medical aid in dying to be authorized in Massachusetts for capable adults with a terminal illness to have the option to avoid unnecessary suffering and a prolonged dying process and die peacefully with loved ones for you, for me, and for everyone. So what can you do? You can call your state legislators and tell them that you're in favor of end-of-life options and ask them to support the bill. Join an action team with Chuck Francis, and his number should be in the chat. Visit Compassion and Choice's website, also in the chat rather, and like us on Facebook. And now I'll turn this back over to Abby on answer any questions. Thank you very much for staying with me and for listening to my talk.
Thank you so much, Dr. Kligler. That was an amazing presentation. We have a couple of questions that are coming in. So if you want to, I just want to remind everyone that you can just go to the bottom of your screen and click the Q&A and type in any questions that you have. I will be giving the questions to Dr. Kligler and then he will answer it. We're going to start with our first question. With terminal sedation, how do you know for sure that those who are sedated aren't suffering even though they can't communicate it?
So terminal sedation is given to make the person comfortable. And my order to the nurses would be to give them enough morphine so that it doesn't appear that they are having any pain or suffering. I would tell them that there's nothing else that's important. Don't check the vital signs, don't give them fluid, don't give them medicine. Just keep that person comfortable. I would talk to the person about it. I would explain what we were going to do. I would talk to the families about this beforehand, and everyone was on board. And interestingly, I worked at a Catholic institution and was able to do this. And this has been gone before the Supreme Court and is considered legal and ethical.
Great, thank you. We have another question that just came in. Why did it die in the legislature last session? How can we help to move it along this time after the Public Health Committee?
I think this was another COVID death. There's also change in leadership in the House. So legislatures are very hierarchical places, and things don't work the way you'd think they do, or we've been taught in school. So you have to have the people up top wanting it to go. And last year, everything was about COVID. If we want to get this to work, we need to yell and scream to our legislators and say, I want this bill. I have two friends who are dying now, and literally dying, hospice or very near hospice. And I know that no matter what I do, these people are going to end up dying without getting medical aid and dying, because once the bill is passed, that's not the end of it. So we need to say to our legislators that we have a sense of urgency, because believe it or not, you're going to die, and you may find that that starts very soon. And, if we don't work on this and get this taken care of now, we may not have it when it's our turn to die.
Excellent. I think that leads us into our next question. I have limited time in my schedule. What is one thing I can do to help this pass in Massachusetts?
The most important thing is calling your legislator. And calls really have an impact on them. So I've met with people, or legislators. I met with a lot of legislators, and they say, oh, I haven't heard enough about this from my district. It's not that important to people. So you need to make this important. They're elected and they want your support. The other thing you can do is join Compassion and Choices. And if you're so inclined, make donations, because money does help us.
Great. Thank you so much. We have another question. When you talk to a lawmaker, what do they say?
It varies. I remember meeting with Senator Lovely when she was not a supporter of medical aid in dying. And she had questions about the safety of the community with the medications involved. And so we talked it out, and she realized that the community would be safe, and that was her, concern. And then she was able to support it. Every legislator has different issues.
Great. Thank you so much. Makes sense that it's not a one size fits all. Our next question is there anything we can do on a local town level that would help support this cause?
So in my town, I started working with the select board to get them to endorse medical aid in dying. I also have gone to work with parties. So I've met with Democrats, I've met with Republicans, and asked them to endorse the legislation, and that would be useful. The other thing is, on a local level, is talk to your neighbors, tell them about this, and help them to understand what is going on, and ask them to call their legislators. And it can be, 1, 2, 3 friends, maybe a few more, whatever you have the time or the inclination.
Great, thank you. I think that's something that all of us can do. So that was the last question that we had received so far. So I just want to remind everyone that you can put any question, nothing's too small, in the Q&A. We'll give it about a minute. If no one puts any questions on, then we'll finish up. Thank you so much for everyone's time. Is there anything else that you would like to add, Dr. Kligler?
I think that I have, this has become very personal for me. As I've stopped working, I've started a new adventure in my life, which is counseling people at their end of their lives and trying to help them. And I always feel like I fail them when they're not able to get medical aid in dying, which they all want to get. And as I said, right now, I have 2 of my friends who are, in hospice, and it's really heartbreaking seeing them going through the suffering. I've got a, handful of people that I've watched it.
Oh, yeah. We have a couple more questions that have come in. Where will this recording be available? Someone is typing that up right now. Will a rep from Compassion and Choices be willing to call our legislators who have questions if we ask them to?
So we meet frequently with legislators. So if you have a legislator who has a question about medical aid in dying, I will be happy to meet with them, and someone from Compassion and Choices will be happy to meet with them to talk about the legislation and to help them get more educated about it so they understand what it's about. Great
Great.
questions.
Are there special provisions for people with dementia or Alzheimer's disease?
This is the sad part. This bill is not perfect. And a lot of people say, I don't want to live if I'm demented. And we're going through this as a family now. My mother has severe dementia and is on hospice. And I realize how that's, it's so horrible. This bill does not cover people who are demented. You have to be able to make medical decisions for yourself. So no, it isn't. But if you go on the Compassion and Choices web, they have something on Alzheimer's, and that might be able to help an individual with some of the options that you can have.
Great, great. In the states where medical aid in dying is legal, how do terminally ill patients find doctors who are willing to prescribe to them?
It's a big problem. First of all, doctors are not trained to give medical aid in dying. There's another article that just came out about a young woman who was practicing in California where it's legal. And a patient came and asked her about medical aid in dying, and she had never dealt about it. He was 45-year-old and said, I'm done. I'm going to die. This chemo is really, making my life unbearable. I just want medical aid in dying. And she had to learn about it. So Compassion and Choices sometimes can help with finding people. It's word of mouth, and you need to really talk. The Massachusetts law has something that's really great that a lot of states doesn't. It says that if your doctor doesn't want to give you medical aid in dying, that they have a responsibility of helping you find someone who will. So if we're talking about Massachusetts and the bill goes through as it's written, that should not be an issue.
Great, great. Just looking through our questions. What is the legislative deadline for the passage of this year term?
So legislative sessions are 2 years. So it just started in 2021 and goes through to the end of 2022, whenever the legislature closes their session. And if the bill doesn't make it through, we have to start again from the beginning.
Great, great. So we got to fight hard this time, right?
We've got to fight hard. We really, we're at the cusp. We've got a lot of supporters in the legislature, but we need to get a lot more. We don't know where the governor stands, and that's important. He could veto it. So we need to get 2/3 of the legislature to be on board with this if he ends up vetoing it. So really, each legislator is important. And please contact your state senator and your state rep. And if there's someone that you saw, like Senator Lovely is your senator, thank her for supporting the bill. Just because she's a supporter, give her office a call and say, thank you, and I want you to help get this passed this year, that I want you to make it priority legislation. And if someone wasn't on that list, call them up, call them out and say, I want this. It's really, really important to me. How do you feel about this? What are the issues you have?
Great, great. Well, with that, we have a few questions in the chat, but Heather Pope, which is another one of the organizers, she will be answering those. And I feel like we can end it there on that note of just different ways that we can fight really hard to pass this legislation.
Thank you all very much for coming. I wish I could see you, but you've been a wonderful audience. Chuck and Joanne?
Just want to say thank you to Roger. That was fantastic, and thank you
Sure.
all for attending this evening. And it's great that you're here, but what we really need is for you to do something, and that something again is contacting your legislative leaders and talking to your neighbors and remembering to ask them to talk to someone. Because if we each have one contact with one person and they have one contact with one person, we will get this done. So thank you all.
It's a great presentation. It was superb, Roger. Thank you.